Hello, my name is Lee Fogel, and I want to welcome you to the Patient to Patient podcast. Today, we have a very special guest for you who's going to give you an insider's view of the healthcare and hospitalization system. That's because he's not only been a provider of healthcare over a long career, he has been a person who's trained medical doctors, and he's also had the unfortunate privilege of being a consumer of intensive care healthcare services because of a serious lung condition that took him all the way down to the point he was on life support, and he had to have a double lung transplant to survive. And he's with us today because of that. And he's a dear friend and a fellow worker in the advocacy work for folks. His name is Dr. Tom Maize, and I'm going to read a little bit of his bio. It would take me 30 minutes to read his entire bio because the man has been involved in a lot of things in the healthcare world. But Tom is now a retired pediatric intensivist and a lung transplant recipient. He's a native Texan. Shout out to Texas and that part of the world where he's from, but he's coming to us today from a different part of the world. He'll explain to you. Tom he's received his degrees from Baylor University, Georgetown University, School of Medicine, and the University of Texas, San Antonio. He's an Air Force ROTC distinguished graduate. He was commissioned as a second lieutenant in May of 1980. Tom served on active duty as a pediatric critical care medicine physician for 8 years. He served practically in every role of direct patient medicine has practiced continuous clinical practice over his entire career, as well as hospital administration. In 1994, he joined the pediatric faculty at UT Health San Antonio. His key medical school administrative roles have been service as clinical dean and president and CEO of the university's physicians group, which was the medical school's practice plan. He also served for 14 years as pediatric department chairman and a year as an intern dean of the medical school. Tom served on the subcommittee on health for the U.S. House of Representatives Ways and Means Committee, and it was during that time that while serving, he was diagnosed with fibrotic lung disease around 2018, and that seriously worsened, and he had to have a double lung transplant in 2021. Tom now serves as an ambassador for the Pulmonary Fibrosis Foundation, and he's on the clinical and scientific advisory board for Vascular Perfusion Solutions, which is a San Antonio company developing technology to extend the viability span of donated organs. I'm hoping he's going to tell us a little bit more about what that means in this discussion. But Tom, I want to welcome Tom Maize. Hello, Tom.
Lee, thank you for your kind introduction, and thank you for having me here today. I'm going to just try to give the viewers a little bit of background so they understand where I'm coming from. First thing I'll say is the view that you see behind me is the view that I have watching outward. I'm on Vancouver Island. I'm looking east across the water. That's the Strait of Georgia or the Inland Passage. And I'm looking at the mountains that you see, which are on the west coast of the mainland of Canada and British Columbia. So that's where I am this summer. I'm enjoying.
That's beautiful. Wow, it's beautiful.
Wonderful Canadian hospitality, and the weather is just fantastic. So, but I'm really pleased to be able to tell the viewers a little bit about my journey, which was unexpected and turned out to be pretty hard. My background, as you mentioned, is pediatric critical care medicine. The first thing I have to tell you is, what does that mean? So I trained in pediatrics, and most people have experience with pediatricians. Pediatric critical care medicine is a relatively new subspecialty, and so we do additional years of training in the intensive care unit, pediatric intensive care unit. We take care of kids from 2 weeks of age until 24, 25 years of age. And I've even taken care of pregnant ladies in their 30s simply because we were better prepared to take care of their particular problems. The gamut of problems we take care of, I took care of kids who got liver transplants, kidney transplants, pneumonia, sepsis, worked in level 1 trauma centers, so you name it, gunshot wounds, rattlesnake bites, motor vehicle collisions, just the gamut of everything. My expertise is in respiratory failure. Now, your viewers, like me as a patient, would go to see a adult pulmonary doctor. And in the adult world, pulmonary doctors are also usually trained in critical care medicine as well. In the pediatric world, we divided years ago. You're either a pulmonology doctor or a critical care doctor. But so much of what I do in critical care has to do with the lungs, and that's really the organ system I'm the most interested in. Now, interestingly enough, we don't take care of kids with pulmonary fibrosis because it's extraordinarily rare in children. In fact, less than 5% of the kids seen by our pulmonary group in San Antonio had any kind of interstitial lung disease at all. So this is all new to me because I just didn't treat this. But I treated a lot of people with respiratory failure. And one of the areas that I have long experience is in a field called ECMO, which is extracorporeal membrane oxygenation. I'll mention it again in my story. But the first ECMO done in the state of Texas was done in January of 1985, and I was on the team that did it. And it was at Wilford Hall Medical Center in the Air Force. Basically, that is taking a life support system like you'd use for bypass surgery, and rather than using it for 4 hours, you use it for days or weeks or even months. So a patient is hooked up to an artificial oxygenation membrane. There's a pump, and the blood is heparinized so that it doesn't clot. And you hope, and it doesn't cure anybody. It's a supportive therapy. It's a way to get somebody to another place. In general, it's going to get people their lungs time to heal, and then they can get off it. And we take care of lots of kids, lots of adults now on ECMO. It really hit its stride in the adult world during the COVID pandemic, and so many patients ended up on adult ECMO because of severity of their lung disease. But going back to my career, I spent 30 years of active practice. That's outside of my 7 years or 5 years of training after medical school as a pediatric critical care medicine specialist. Okay. And I took care of all those things I just described to you. I had the fortune of also being a teacher of medicine. So I taught medical students how to be doctors, who wanted to be pediatricians, how to be pediatricians, and pediatricians who wanted to do pediatric critical care, how to do that. So I've had an extensive background. But the one thing I'll tell you, because it's very ironic, is the only place I practiced was inside of a hospital. And I loved hospital practice. That's what I did. That's where I worked. I didn't work in a clinic. I did on occasion, but not very often. And I found a lot of joy in taking care of sick kids. What's nice about pediatric critical care, as opposed to adult critical care, is that the vast majority, and I'm talking like 98% of our patients leave the ICU alive. If you go to the adult ICUs, that's not quite the case. It's anywhere from 30 to 50% will die in the adult ICU. Okay, that's
Wow,
different.
that's amazing. That's a huge difference. I didn't realize that. Wow.
Yeah. So just so you know, pediatric ICU medicine is happy ICU medicine because most of our patients actually do well. Another group of kids we took care of are kids with congenital heart disease, born with defects in their heart. Very, very extensive programs in that. Very state-of-the-art kind of things I was doing. So I had a really blessed career. There's no greater privilege than to be a doctor.
Yeah.
Okay.
Yeah.
So I was up in Washington, D.C., because I had been doing advocacy for pediatrics, for children's hospitals. And I was interested in learning more about health policy. And I was a Robert Wood Johnson Foundation Health Policy Fellow for 1 year, living in Washington, D.C. And I was working on the subcommittee for health, the House Ways and Means Committee, that has jurisdiction over Medicare, by the way. And you're on Medicare, I'm on Medicare, a lot of us are on Medicare. At the time, that was $600 billion a year that was to spend on Medicare. It's a lot more now. But I was working in that world, and I had a routine physical exam, feeling fine, doing great, great shape, and I had interstitial lung disease. And my doctor called me. He's pretty upset. I said, "No, man, I just saw you last week. Everything's fine. I'm in great shape, you know. I'm walking 5 miles a day, but blah, blah, blah." And so what was very unique about me was that I actually had no symptoms of anything, no cough, nothing when I was diagnosed. So I immediately, then I got back to San Antonio where I was working after my fellowship, and I got connected with at a pulmonary fibrosis clinical center with a specialist in interstitial lung disease. And so we went down the path of trying to figure out what my problem was. And because of my impatience, I went ahead and opted for an open lung biopsy 11 months after I was diagnosed with interstitial lung disease. Now, what was unusual is I was not on oxygen, I was not on medication, I had normal pulmonary functions. And the surgeons were like, "You're crazy to get a biopsy." I said, "No, I'm not, because I actually want to know what I have, because then I can plan accordingly." So I think one of the things for viewers is to try to get as much information as you can whenever you get told that you have pulmonary fibrosis, for instance. Now, that's getting it from your doctor. I'm going to say the Pulmonary Fibrosis Foundation, which I was very late getting introduced to. It's an excellent source of information.
So mention that name again. You passed it pretty quickly. It's the Pulmonary Fibrosis Foundation, where you're an ambassador. And what is that organization?
So it's a nonprofit uh, organization that's really devoted to providing education and resources to people who suffer from pulmonary fibrosis.
Right.
Pulmonary fibrosis, estimated in the U.S., 250,000 people with it.
Yeah.
50,000 new diagnoses a year, and 50,000 come off because, unfortunately, with the
Yeah.
exception of a transplant, which again I was blessed to receive, it's a long haul, and there's no silver bullet right now to cure it. Hopefully, in the future
Yeah.
there will be. But the fibrosis is a lot of volunteers. You're a volunteer. I'm a volunteer. But they provide great resources for patients with lung disease. Caregivers.
So I joke sometimes with the folks because we're a well-kept secret because so many pulmonologists are not they are aware of the organization, but they don't tell people when they get a diagnosis, go here rather than go to Google and search and find all the weird stuff out there. Go to the Pulmonary Fibrosis Foundation and get the real scoop on the basics of the disease, etc.
I'm a well-trained, respected doctor, but I'm a pediatric doctor. And I was seen in 4 centers that are pulmonary fibrosis clinical centers, and not once was it mentioned to me as a resource. Okay. I guess maybe somebody just assumed I would know that. And so, I knew a lot about my disease, but all I'm saying is, number one, I got a lung biopsy because I wanted to know exactly what I have. It's imperative if you have this disease and you're going to manage it with your health care team and your caregivers, that you have to have a lot of information. So number one is get as much information as you can. So I did all that. And again, it was crazy because I had no symptoms. So lung biopsy in June of 2017. 1 week later, to the dismay of the surgeon who did my lung biopsy, I was whitewater rafting on the Rio Grande River near Taos, New Mexico. Okay. So I'm a guy who's doing okay. I have lung disease, but I'm not feeling it. That November of 2017, I'm riding a bicycle in the Andes at 11,000 feet. I'm telling you,
Amazing.
I'm doing fine. Well, as it turns out, in early 2018, because of what I did for a living, which is to take care of sick kids, I got influenza from a kid despite immunization, and I got over it. And then I was struck with sepsis and staphylococcal pneumonia, and lost a third of my lung function then. Okay.
Wow.
But still no oxygen, still no medications. Then I went another year and a half before I started having symptoms. And my symptoms were progressive shortness of breath And basically, I felt crappy most of the time. I just didn't
Mm.
feel good. At that time, I was working in my hometown of El Paso at an altitude of 4,200 feet, and the air quality there was terrible. So here I'm going to say, I measured, and I still do, every day, everywhere I am, I measure what the air quality index is. The EPA has an app. There's a company called Plume, Plume, out of France that has what I consider to be a better app. But I can tell you what the air quality is where I'm sitting today. I could look it up where you're sitting because I think if you have lung disease, it's prudent to stay out of bad air. And if you
Mm.
have to be outside in bad air, that you wear an N95 or equivalent mask to filter out dust particles and whatever. So anyway, so I was working, I had a job, I was taking care of sick kids. I started feeling bad. I had a follow-up pulmonary function test in May that were stable at 70% of lung function. And then I had a repeat in December and I was down to 30%. And that's why I was feeling bad. And
Wow.
and then this is the end of 2019. So I went for over 3 years without anything, that was wrong with me. I talk about symptoms, nothing, no symptoms. Then I was put on high dose steroids, which was not a pleasant thing for me. It's kind of standard. Then I was put on another immunosuppressant. I rapidly deteriorated, and I characterized it as I was a dude who fell out of the airplane and I didn't have a parachute on. Okay. That's what it was like for me. And all of a sudden, I couldn't walk half a block. I couldn't breathe. The steroids made me feel great, but they didn't help my lungs at all. And so within 3 months, I'm on oxygen. And then I was actually in New York City getting my care there, and COVID hit. And I was out of luck because it was all COVID all the time and nobody would see me. My usual doctors said, "Oh, I'm sorry, we're only seeing COVID." So I went back
Yep.
to San Antonio. And by July, I was on the transplant list for a double lung transplant in San Antonio. And then it was really an awful experience, waiting. And at the same time, my oxygen requirements were going up. And so by November, I was at rest. I was at 2 liters per minute of oxygen. When I got up and walked around, I was on 15 liters per minute of oxygen.
Oh. Wow.
And then in mid-November, I was I had my saturations, which of course I'm checking all the time. I have so many pulse oximeters. I could own a company by now. I bought so many of them, but my sats were dropping in the 70s on 15%, 15 liters per minute of oxygen. So I ended up taking a little trip in the ambulance to the hospital. And the next day, I was offered the option of ECMO. Okay, that I described this earlier. This is lung bypass as a bridge to transplantation. And I initially was very resistant because I was an ECMO doctor. So, I actually knew more about ECMO than the people offering it to me in terms of experience. And, it's a technology that's life-saving, but it has immense risk associated with it because
Mhm.
you're heparinizing the blood. You have risk of strokes and other hemorrhages, all sorts of infection, a lot of risk involved. But I ended up talking to other physicians, uh, actually at Columbia University in New York, the number one place doing bridge to transplant with ECMO. And I talked to a guy named Dan Brody, and he suggested that if I'm in San Antonio, that was a reasonable candidate to do that. And the right guy to do it was a guy named Phil Mason, Dr. Phil Mason, wonderful man, saved my life. And at that time, Dr. Mason was walking in with the ECMO team, and I was put on ECMO awake. And I was transported from University Hospital to a military facility. Okay. Now, that
Mm.
program that I was on, the adult military ECMO programs, a descendant of my pediatric ECMO program I started when I was in the Air Force. Okay.
Mm. Wow.
So
Wow.
it's like this
You,
full.
you you built it for yourself.
Yeah. And so I will tell you that because of complications I had, The main one being immune reaction to heparin, the blood thinner, causing my platelets to go to zero. I ended up staying on ECMO not for a week or 2 weeks, but for 101 days, 3.5 months. And here I was at a military facility, which I'm very comfortable with because I worked in one. I will tell you, I got nothing but great care, fantastic care.
It's terrific.
I just got fantastic care. And I kudos to the nursing staff that took care of me, San Antonio Military Medical Center. They were fantastic. Physical therapists at San Antonio Military Medical Center, fantastic. One of the things about being on ECMO as a bridge to transplant is they don't want you lying around. They want you up and moving. And so one of the things I endured because it was no fun, and you have some photos of this, is I was able to get up with a lot of help and walk around the ICU on this life support machine.
And while you're talking, I'm gonna share my
Okay.
my I'm gonna share some pictures, but you continue. I'll bring some pictures up here.
And so that was really an endeavor. Now, when I did ECMO with kids, this was inconceivable that we'd have a child be awake and walking around. So the picture that's on the left to the viewer, you're looking at my backside there.
This woman, I thought she was about to pull your dress up there, Tom.
Yeah, well, they made me, they're very, that's a physical therapist. She's great.
So wait a minute, you're hooked up to an ECMO machine, which has got the blood
I'm
coming
hooked
out
up
of
to
your
the
body.
ECMO machine. Now,
Oh,
you see
you're
the
not
nerve, the person way up in front with a mask on,
right,
not a hat, she's pushing the ECMO machine, okay? That's the nurse
right.
pushing the ECMO machine. The physical therapist is holding me up with one of those physical therapy belts. On the right-hand side, you're seeing a respiratory therapist who's pushing my BiPAP machine. Now, I was never intubated, I never had a tracheostomy tube. I refused all that because I wanted to know, I want to be awake. And then in front of me on the right-hand side, there's another nurse to just kind of take care of anything that comes up. And you see the elbow of a physical therapy associate pushing my chair that I would fall into when I had to stop.
So Tom, for the viewers, because I compressed these two photos together. We're only looking right now. You're describing the photo on the left side, which is the ladies and the nurses and such in the aqua colored green gowns, and you in the center of that picture.
Right.
But here's what I found amazing is everybody I've ever talked to who's been on ECMO has been completely bedridden in the bed the
Yeah.
whole time. And this is what I so encourage so many people who are hospitalized to do, is to continue to move. And it's really great that these physicians, these nurses got you even on an ECMO machine,
Yeah.
and you were moving. Now you were there 104 days
But
on ECMO, which is some kind of record.
but
And
but but look at
that's
how many people are involved. This is a real
I get that. It's not an easy thing. Let's get up and walk you around for a minute, sir. It's put the whole team required. So that's pretty amazing to me. The other picture on the right side for folks, I just thought this was marvelous. But
it was a marvelous day. So this
yeah,
was in January of 2021 is when this photo was taken. I had been on ECMO for over 8 weeks at this point. Okay. And it was a beautiful day in San Antonio and it was warm outside, which not surprising in South Texas. So they took me out and they took 5 or 6 of them to wheel me out. I was out in front of the hospital and there I was, and you can see that I have a BiPAP mask on and you can't see the ECMO machine because it was to my left. It's out of the view of the picture, but I was on my ECMO machine. I actually got a little bit of a sunburn because I was so pale.
Tom, I find that just phenomenally great for the hospital to do. I'm a huge advocate of sunlight therapy for so many ailments, and getting some measure of sunlight on our skin each day for vitamin D and just overall health. And hospitals are notoriously bad. Patients never see the sun, and this isolation that they're in there, and all the machines
Yeah.
going.
Well,
And
well, I'll
this is beautiful.
get to the not so good parts of the hospital pretty soon.
Okay.
But I'll tell you, when I was at San Antonio Military Medical Center, I was treated like a king. Okay, and
Right.
they were great.
Wonderful.
Now, when lungs became available, which was the end point for me, right? And I was actually getting sicker and sicker. Um, I was transported back to the university hospital where my transplant took place. And my transplant, and I don't think you've heard this part of the story, Lee, is that it was a 2-day adventure because I had horrific bleeding and I required 45 units of blood.
Oh my gosh.
And it was really quite harrowing. And I have to give, we need to remember our caretakers here. And God bless my wife.
Mm, yeah. Wow. It's great to have that person with you to go
Yeah,
walk alongside
so
you. Mm,
so I'm a pretty good advocate for myself, but there were times when I could not be an advocate. Now she's
right.
in the care world, she's a psychologist, but boy, she could be a bulldog when I needed a bulldog. And
That's
so
good.
I'm very blessed that way. So then, because I was pretty sick when I got transplanted because of all this bleeding and all sorts of stuff, rather than me going home in a week or so, which is the normal for people who get transplants, by the way, okay, elective transplants. Um, I spent another 5 or 6 months in the hospital. Now that part of the hospital experience was not so pleasant. And this is what I describe my experience as being a prisoner of war. So I was trained as an Air Force officer during the post-Vietnam era. We were trained on what to do if we were captured in terms of resisting. It's supposed to be name, rank, serial number. But we would be, we'd basically be tortured for information. So they were trying to teach us what to expect. So they teach you that you would be exposed to extremes of temperature. I was freezing the entire time I was in the hospital, both hospitals, right? I was freezing. People kept
Mm,
turning the air conditioner up, so they were cool, and I was freezing cold. Number two, I was isolated. This was COVID. Everybody was wearing masks and gowns. Um, because I was somewhat privileged in my background, my wife was able to visit me whenever she wanted to. That was not the experience for most patients, however. So there was an immense isolation involved. The third thing was sleep deprivation. And so much of this is just crap as far as I'm concerned. That somebody will wake me up at 2 in the morning to get vital signs. My vital signs have been stable all the time. They could get vital signs at 12 and they could get me at 6, be perfectly fine. I wasn't unstable. And then my best friend was the dude who came by at 4 in the morning to wake me up to take a chest x-ray, right? Well,
amazing.
I've been around
Amazing.
long enough to know why that happened. They used to have to go develop the film in chemicals. Now it goes up. I saw my x-ray before the doctors did. And then they woke me up at 5 to get labs, and then at 6 to take medication, blah, blah, blah. And the last thing was just the incredible amount of noise in a hospital. And so I'm a hospital guy, and I knew the levers to push. But these are things that are built into the system. This is not the people taking care of me. This is the way that hospitals are run. And for a lot of it has to do with money, to be honest with you. I will
Yeah.
tell you that with rare exception, everybody that took care of me was wonderful. And in fact, some people were actually very courageous. But the hospital experience that I had, and as you know, I give talks to doctors about this, is what they can do different, is something that people need to be prepared for. Now, the one thing I will say is the word transplant is scary. It's scary, okay?
Right.
And for people like me with pulmonary fibrosis, if we're a transplant candidate, it's your only hope of survival long term.
Right.
But it's not without its own issues at all. So, transplant, I told you, I could have bled to death, but fortunately someone caught my bleeding and I was resuscitated with the 45 units of blood. So this it's not a trivial operation. This incision for a lung transplant, double lung transplant, goes from armpit to armpit, and it's a big surgery. But I will tell you that I have gone and seen numerous patients at the request of the ECMO doctors to tell them the positive aspects of getting transplants. And so I will say to your viewers, if somebody wants to talk to you about transplant, you need to listen to it. And if you're worried about it, actually, you can track me down and just call me and I'll talk to you about it. Because, it's scary. All those things are true. But I'm sitting in beautiful British Columbia right now talking to you 4 years, 4 months, and what is today? This is the ninth and 9 days after my double lung transplant. And
That's amazing.
it's been a
That's such a
hard
blessing.
road. It's been a
Yeah.
hard road. One thing I'll mention, and because you and I talked about this, is palliative care. And
Yeah, I want to go into that. But one thing I want
yeah,
to
any
remind.
questions you have, I'm happy to
Yeah,
say.
so I want to. There's some. I had one thing I want to go. First, let me do this one thing. I have. There is. Let's see. What was the other question? Well, anyway, I will remind our listeners on something though. If you're listening to this and watching Tom today, can you do us a favor? Uh, the way we get this information out is something called the YouTube algorithm. You may be familiar with it, and but if you just watch this video, you find value in it, and you don't interact or do anything, YouTube's going to assume you didn't like it, and so they're going to, must not be very interesting content, so they won't automatically pop this up on the feed of somebody who searches for lung transplant. So the way that we change this the way that you can help us change this to make sure that more people hear about Tom, who's now just volunteered his own time to answer questions and through this chat and through the comment section on this video. Put your questions in there for Tom and me. But anyway, so the way you can help us with that and get more help other lung patients is find that like button, the thumbs up, give it a thumbs up, subscribe to the channel. We don't send you information. You're just subscribing to the channel will alert the YouTube algorithm that this is valuable content for you. And if you have comments or questions, please, by all means, put those in the chat thing. Ask us a question. I answer questions all the time from people all around the world on this channel. So please put them in. We read those and we respond to them. And Tom has graciously offered that help. If you've got a loved one or you are worried about a transplant or thinking about it, an ECMO and all those things, he's a great resource for us. And that's part of what we do to give back to the life that we have today. So back to you, Tom. I want to talk, this thing of palliative care is a term that I hear folks, you brought it up recently, and I hear people who are they think I work I'm a volunteer in hospice. So I spend a lot of time with hospice patients. Palliative care is not hospice. I'm gonna give you a quick definition. Is palliative care is a specialized medical care focused on improving the quality of life for people with serious illnesses, regardless of age or stage of illness. So it can, at any point in time with pulmonary fibrosis, this oxygen cannula I'm wearing, this is palliative care. It makes my life comfortable and keeps me comfortable so I can exercise and move around. So the care is not limited to end of life type situations, and it can be beneficial at any point during an illness. So Tom, talk to us more about that from a
Well,
physician standpoint,
I
palliative
think you
care.
covered it pretty well, Lee, because I will tell you, I actually know a lot about palliative care on the provider side. Okay, number one is that we developed in 2005 a pediatric palliative care program in San Antonio as an outgrowth of our hospice care for cancer kids, because
Okay.
we identified that people had needs that were not end of life needs. They were other needs.
Right.
So what I'll say about palliative care, and you gave the correct definition, but it's also curative care. It's not, okay, we're going to make you comfortable and nothing, not much else, which is kind of hospice on some level. It's curative, but it's a different state of mind, is what I'd say. Right.
Yeah.
So this is not an appendicitis, you get an appendectomy and you're okay. This is for people who have chronic serious illness. But and it's sprouting up all over the place. Now, and I've actually covered for my palliative care doctors in San Antonio. So, I'm very well versed in it. So when somebody came to me, when I was on ECMO and said, "Are you interested in palliative care?" I said, "Well, hell yeah, I'm interested. Yeah, of course I am." And so I'm a guy who's on palliative care, and I can guarantee you that doesn't mean hospice care because I'm here talking to you. And
Right.
so I think it's unfortunately it's confused with hospice care. But I would urge any of the viewers that you are watching this, or families or caregivers, that if there's palliative care available, not to confuse it with hospice care, which is very easy to do, but to also remember that it's curative. It's not giving up. It's making a person's life better in the context of a serious and sometimes a terminal illness. And so I can't say enough about palliative care in a positive way.
Yeah, that's good. Are there any other than the things that will enable you to continue to live and move and be active? Are there any type of medications that are
Right,
particular for
right.
palliative
So
care?
yeah, so you get a transplant, organ transplant, doesn't matter which one it is. You're on medication the rest of your life. You're on immunosuppressive medication. Now, and I'm on every day I take three different medications for immunosuppression. And that's the usual thing is people are taking at least two, but probably three.
Only three medications that you're taking every day?
One's called tacrolimus or
And
Prograf.
I said it's only three. I always thought of
No,
lung
no, no,
transplants as having
three.
a
No,
box of.
I said there's three medications. I didn't say how many pills I took.
Oh,
Okay,
oh,
those are
okay, okay,
three immunosuppressants that I take every day, and
yeah,
that is 6 pills.
okay,
Plus, I'm a guy in my 60s, and my cholesterol's up, and I have some bone thinness. I'm on calcium, and I'm on a lot of other stuff. But in terms of immunosuppression, it's three drugs. I'll be on those the rest of my life, and if I stop
okay.
them, I'm going to reject my lung.
I got
So
you.
and some people can say, I'm not willing to do that, and that's okay. That's
Yeah,
okay, because you have to make a commitment to do it. And the last thing I want to do ever is that somebody died and I got their lungs. And I
right,
honor that.
right.
I take good care of my lungs,
Yeah,
right?
yeah,
So,
really.
and because I'm immunosuppressed, I wear a mask on an airplane, even though nobody else does. If I'm with friends, I don't. But if I'm in a crowd, I wear a mask. When I go to church, I wear a mask. There's a lot of people there, and so I'm very cautious. I have 4 grandchildren. Any one of those grandchildren has a snotty nose or a rash, they don't get to see their grandfather,
Uh-huh.
period. Which is unfortunate, but that's just the way it is. But I'm traveling. I haven't gone over an ocean yet, which I used to do, but here I am. I'm in Canada, and I travel without a problem. And I haven't been on oxygen since about 4 days after my transplant.
That's beautiful.
Yeah,
Wow. I've been on auction for 5 years now. It's kind of
yeah,
like putting on glasses and wearing glasses. I
yeah.
don't have
I
to wear
gotcha.
glasses,
I
but
gotcha.
I'm never without. I'm tethered. So for you, that's wonderful. You're no longer tethered to an oxygen tank. It's not that many. I always thought of it being an ungodly number of medications you have to take for the transplant. There's 6 pills a day, and you seem to be doing so well
I'm
with
doing
this.
very well.
Yeah.
I will tell you the other thing I do, which is more important, is, and I ask you to reschedule this today, so I could have my aqua physio. That's aqua pool physiotherapy in Canadian speak, okay? And I'm doing that
Okay.
3 times a week, and I have a personal trainer twice a week, and so
So you exercise a lot.
I exercise.
That's
I
excellent.
exercise to the degree I can because I got a bum knee, and that's a problem for me
Right.
right now. I'll get that taken care of though. But what I would tell your viewers, number one, is if you have pulmonary fibrosis, if you have that, my adult medicine colleagues don't communicate very well sometimes, and they just deliver news in a bad way. Now, if you could to come see a pediatrician, I'd be much kinder in how I would talk about it. Okay. I wouldn't say, well, you got 3 to 5 years, which is a common thing I hear from patients who have pulmonary fibrosis. That's kind of old information actually, and it all depends on how old you are when you're diagnosed, how good you take care of yourself, how well you work with your healthcare team and your pulmonary rehab, and all the things that are available to you. Do you wear a mask when you're outside when the air quality is bad? I mean, there are all sorts of variables here. But I would say also if somebody mentions transplant, which is a scary thing to hear about, I'm here to tell you that I'm really glad that I did what I did because I wouldn't be talking to you otherwise.
Yeah. Yeah, I think, well, you said a mouthful a minute ago about the just the preparation for that and how just for patients in terms of the exercise and the way that you take care of
Yeah.
yourself and
Yeah.
how and what that means. That the real mouthful is that in the diagnosis of 3 to 5 years, I hear so many folks are lamenting the fact that they're
Right.
nearing the
Yeah.
end of their life. When I first was diagnosed, I got that, and I proceeded to go from being an athlete, part time, and a CEO of a company to sitting in a recliner, you know, 12 hours a day and sleeping the rest of the day,
Yeah.
depressed, and I declined, terribly declined. Couldn't walk to my bathroom, and I just until I
Well,
turned around mentally and said, okay, I'm gonna fight this thing, and I don't believe that 3 to 5 year thing, and which that's made all the difference. It's been 5 years, and I'm
but
healthier than I've been before the accident, except for I got some lung damage and I have to wear oxygen. But it's just critical to continue. I love the fact that you're still exercising, and lung transplant doesn't prohibit that. You're active and doing those things.
and
Clearly,
I also want to say that I'm an outlier on transplants. Most patients at the center I was transplanted on who are transplanted have pulmonary fibrosis, IPF, or one of the other fibrotic lung diseases. And most of them are out of the hospital within a week or two after their transplant.
wow.
They don't do what I did, which was live in the hospital for months.
Yeah.
But all I'm saying is that what I really want to say, Lee, is that I hope I'm giving people a message of hope. Okay. But if you're in the hospital, be prepared to it's not a pleasant place to hang out, number one. But also you need to advocate for yourself, or your loved one needs to advocate for you. You can ask them to hang a sign on the door not to wake you up in the middle of the night.
Heck yeah,
All
that's
sorts of
awesome.
things you can do. Now, whether
Right.
they do it or not is variable, but you can ask
Right.
them.
Yeah.
And so, as you know, I was pretty connected with the hospital I was at, and I wrote the hospital CEO love notes on many nights, which were emails outlining all the opportunities they could have done better that day in my care.
That's
So,
beautiful. Yeah,
yeah,
that's good. Make your voice heard. So before we close, Tom, I want to remind everyone that the information provided in this video is for general information and educational purposes only. It's not intended to diagnose, treat, cure, or prevent any disease, nor should it be considered as a substitute for professional medical advice, diagnosis, or treatment from your own physician. Always seek the guidance of your physician or other qualified healthcare provider with any questions you may have regarding your own health or a medical condition, and never disregard professional medical advice or delay in seeking it because of something you may have heard me say on this video. Furthermore, there is no commercial affiliation with any product or service we ever mention on this video. It's just stuff that we've used. And anyway, so that's our little disclaimer. So please remember that. Tom, any closing
yeah.
thoughts or comments for the folks?
What I would say is that this is a journey. We know it's a journey we're all on, and we all have a different journey. But there's a lot of common denominators, and I think that the things that you do, you're an inspiration, Lee, by the way, given where you've been and where you are now, and your attitude. Everybody thought I was going to die, except for one person. I never believed I was going to die. I just,
Wow. Good.
whether that's my ego or whatever, I don't know, but I never believed I was going to die. I was prepared to die, but I never believed I was going to die. And I think that your mindset is so important. And the second thing I'd say is if you have a question directed towards me, put it in the chat. Lee will get it to me, and I'll get back to you. And I'm happy to talk to you on the phone. Happy to talk to you by email. But I'm not your doctor. I'm going to echo that I'm a baby doctor. I'm not your doctor, and I'm a retired baby doctor. So I'm not going to give you medical advice other than tell you how best to work in the system with the right doctors, healthcare providers, rehab people, etc.
Right. You're talking to just that's the name of this podcast is patient to patient. We're patients talking to patients. And here we happen to have a patient today who's also steeped in the medical world of practice and has done so many different things. So Tom, it's been a great pleasure hearing
Thank you
about your
very much for
story
having me.
and all
Appreciate
the
it.
work that you're doing. And we need to make Pulmonary Fibrosis Foundation more well known out there and help them find a way to get that on the tip of every doctor's tongue so that folks
I hope
can
so. I
not
hope
be
so.
in the dark about
Hope
all
so.
the information that's available. Anyway, thanks so much, Tom. It's been a
Thank you
great
for the
pleasure.
opportunity to tell my story. I
Yeah,
appreciate
well,
it.
thank you, and enjoy that beautiful scenery. And
I,
you're honoring the giver of those lungs with your life now. You're and the
uh,
work you're doing. You're honoring those lungs. So
I am.
may they continue to be blessed and provide life for you and encouragement for many
Yeah.
people.
And I would say in parting is that I'm here because of the grace of God, and I say God bless anybody watching this show,
Yeah.
because whatever that is, whatever that means to you, it's important. And so thank you very much for having me. Really
Thank
appreciate
you,
it.
Tom. Thank you. It's been a great pleasure.
Take care now.